It gives me great pleasure to introduce Dr. Adam Szulewski, and his talk is an ER doctor's secrets for peak performance.
I'd like us to do a quick exercise together. I want everyone here to take a deep breath in and hold it, and now exhale slowly. So you'll see the connection later on, but for now, suffice it to say that that little exercise is going to help me deliver this talk to you tonight. I'm going to tell you a story, one that some of you may find a bit intense and overwhelming. It comes from my professional world, the world of the emergency department. And though it might be a bit difficult to listen to, this type of story is real, and it's not rare. I want you to imagine that you're the trauma team leader, so the doctor in charge of looking after traumatically injured patients when they arrive to the hospital. It's 3 a.m., you've been at the hospital since 8 a.m., and you're tired. You get a phone call about a 15-year-old boy who's coming into the hospital after being involved in a snowmobile crash. He smashed his snowmobile into a tree, traveling at highway speeds. He's not doing well. You assemble your trauma team, about a dozen doctors, nurses, and other healthcare professionals into the trauma bay. This is not a big room. As they start to arrive, you realize that it's starting to get hot in the room. There's a bunch of beeping monitors, there are some side conversations going on, and you find that it's getting harder to think because it's getting loud in the room. The child arrives with paramedics. He looks severely injured. He can't speak. He's groaning in pain. His vital signs are abnormal, and his leg is deformed. The nurse can't feel a pulse in it. You look around at the members of your team, the junior members, and there's a look of fear in their eyes. You can feel your heart rate starting to increase. Just then, the patient's parents walk in the room with a devastated look on their faces. Just beyond them, you can see a line of paramedics with new patients all the way out the door. Despite the training you may have, you realize you're not firing on all cylinders. That state of mind, that feeling, is cognitive overload. But you don't have to be a trauma team leader or an emergency doctor to have felt cognitive overload. In fact, I bet every single person in this room tonight has felt cognitive overload at some point in their lives. Do you remember the last time you drove in a snowstorm and the snow was starting to come down harder and harder? Your tires started to lose grip? What's the first thing you did after you slowed down? You turned down the radio. What about the last time you were in a new city looking for a place to eat because everyone was hungry, and then your kids started to yell at each other in the back seat? Do you remember saying, "Everyone be quiet, I can't hear myself think"? Well, that too is cognitive overload. And I think that thinking about this is fascinating because nobody taught you to turn down the radio. Nobody taught you to ask for silence, but you did those things anyway. You did those things because they're a performance strategy, one that's designed to help you focus on what's important and drown out the noise around you. I'm an emergency doctor and a trauma team leader at Kingston Health Sciences Center. My academic work at Queen's focuses on trying to better understand how doctors make decisions in environments that seem to have been designed in ways to make us fail. The truth is, there's a huge amount of emotion, stress, anxiety, and uncertainty in our clinical worlds. Yet despite this, some doctors perform at incredibly high levels. Now, although the focus of this research is to better understand physician decision-making under pressure, these lessons apply much more broadly. They apply to any complex professional field. They apply if you're a parent. Conveniently, they're also really useful if you're giving a talk to a live audience. Now, I remember being cognitively overloaded fairly often early in my training, and though I could describe what this feeling felt like, it was only during my PhD, which was in educational psychology, where I learned the background and the theory behind cognitive overload. And what I realized is the way that I felt when I was overwhelmed in a clinical situation was the same way that students feel when they're overwhelmed in a classroom or during an examination. And I realized why reinvent the wheel here? Can we take the lessons we've learned from educational psychology and apply them to leading a team in medicine? Now, when I was a resident, I remember looking up to my supervisors and thinking that some of them just had it. And there was this one supervisor in particular who really had it. He was able to keep all of his thoughts and emotions in check during a clinical situation that was very difficult, whereas my thoughts and emotions seemed to be out of control. He was able to expertly manage the patient, update the family, teach the medical student, and then see the next equally sick patient without missing a beat. And I couldn't understand how he did this. Somehow he was able to turn the radio down and keep driving through the snowstorm. And when I asked him about it afterwards, he had a really hard time putting his finger on it. He said things like, it comes with experience and practice. But what did that really mean? Something about his thinking had changed with time. His cognitive architecture had evolved. And what I realized is that if you want to understand human performance and eventually optimize it, you have to understand the limitations of the human mind and the cognitive efficiencies that experts develop over time. Now, when we think about cognitive architecture, we have to understand human memory. And human memory is made up of three main parts. There's sensory memory, long-term memory, and working memory. Sensory memory is involved in dealing with all the stimuli around you, the sights, sounds, tastes, smells, and things you can touch. And there's a staggering amount of that stimulus around you. And sensory memory is involved in dealing with those things by briefly holding on to those pieces of information after they're gone. Do you remember the last time you were speaking to your daughter and you were pretty sure she was ignoring every single word you were saying, but somehow she could still repeat the last 3 words that you said? Well, that's for sensory memory. Now, on the other side of memory is long-term memory. And long-term memory is where we store information that we've rehearsed and we've elaborated. And long-term memory is thought to be limitless. And the place in between sensory memory and long-term memory is working memory. And working memory is a fascinating place. It's where we elaborate, we rehearse, it's where we manipulate information, and where we think. But working memory can only hold on to about 7 discrete pieces of information at any specific time. And that's why, in the day before smartphones, and I can remember those days, that's why phone numbers were 7 digits long. And although the amount of information in working memory, those 7 pieces, will never increase with time, with expertise, what you can do with each of those elements becomes richer and more complex with time. Let me give you an example that might help illustrate this. When I was a medical student, I remember learning about heart failure. Heart failure was a complicated topic. I remember learning that patients in heart failure might have a history of cardiac issues. They might have trouble breathing, especially when they lay flat. And when they come to the hospital, they might have low oxygen or high blood pressure. And I might be able to give them a water pill to treat them, or I could put them on a breathing machine to take away their work of breathing. That's 7, and my brain was full. But after years and after having seen lots of people in heart failure, I think about heart failure a bit differently. I think about what heart failure looks like and what I can do about it. And so I have more pieces of my working memory available to do all the other things I need to do, like update the family, or teach the medical student, or see the next patient. What's happened with time and with expertise is you start to chunk information and you reorganize it in your brain a little bit. But knowing your stuff is just part of the battle. What about all those distractions that we talked about in the emergency department? Are there ways to learn to deal with those things? Well, the truth is, there are ways to learn to deal with those things. And we've been studying experts in action, experts in the real world, to try to figure out what those strategies and those thinking processes are. But it's really hard to study experts in action. First of all, experts are really bad at remembering what decisions they were making during a case after the fact. And not only do they not remember the decisions they were making and the strategies they were using, they actually don't see those things as decisions and strategies at all because they're just so obvious to them. they develop what's called an expert blind spot. The other thing that makes it difficult to study experts in action is the fact that you can't interrupt a doctor when she's resuscitating a complex patient. So what we've tried to do with our research team is to try to get around some of these issues. And what we've created, this novel technique that we've come up with, is something called re situ interviewing with eye tracking. So what we do is we take a pair of mobile eye tracking glasses that look very much like a pair of eyeglasses, and we put them on our experts just before they walk into a stressful clinical situation. And then what we can do is afterwards, we can sit down with that expert and we can watch the video that was created from these eye tracking glasses with a superimposed gaze indicator, and we can interview that person and we can figure out what the thought processes were. And then we can pause the video and we can probe deeper. By doing this, we've come up with 3 main ways that experts differ from novices when it comes to their approach to dealing with difficult situations and managing cognitive overload. Once you understand these 3 main themes, I think you too will be able to use them in your own life. You don't have to be a doctor managing a trauma. You can be a nurse in the same room, or you can be a police officer during a high-speed chase, or a chef in a busy kitchen, or a parent dealing with a family crisis. The first thing we've learned from our experts in action is the importance of mental simulation. So if there's time before a sick patient arrives, the doctor will often bring the team together and lead what we call a pre-brief, explaining what's coming, and then that doctor will often ask the team members to mentally simulate what they're going to do in the first minute after the patient arrives to prepare. For example, if we hear that an unconscious patient is coming into the hospital, the nurse might think ahead and get medications and drugs ready that might be ordered and anticipate. It's been shown that teams who practice to mentally simulate for just 1 minute and think about what they're going to do in the first couple of minutes after a patient arrives have a measurable increase in their performance. And we think this is because they're priming schemas held in their long-term memory, making them easier to access, and therefore having more working memory resources freed up to perform when it matters. The second thing we've learned from studying our experts is the importance of something called selective attendance to information. And this is maybe best seen in some of our simulation work. There's this one case in particular of a simulated patient, an older person, with a rupture in his aorta. And the aorta is the big blood vessel in the body. And you can imagine when the aorta leaks or ruptures, it's a medical catastrophe. And it's interesting to see how novices respond differently to our experts in this simulated case. So as part of the general workup of any sick patient who comes to the hospital, doctors are often given an ECG, which is a piece of paper and it's a heart tracing. And an ECG is quite relevant for patients with chest pain, but it's not always relevant. In our simulated case with the older patient with the rupture in his aorta, our novices are given this ECG and they stare at it. And we can watch with our eye tracker how they systematically go through the ECG, because there has to be an answer here somewhere that's going to tell me what I need to do next. And it doesn't matter what's going on in the environment. But do you know what our experts do? They take the ECG, politely put it aside, and then they pick up the phone and call the one person who can actually fix a leaky aorta. That's the vascular surgeon. The third thing we've learned from studying our experts in action is the importance of psychological skills. And one of those psychological skills is rooted in one of our most basic human behaviors, breathing. Do you remember the exercise we did at the beginning? Taking a breath in, holding it, and then exhaling slowly can decrease the amount of anxiety and stress that an individual is facing, allowing them to perform better. The other thing related to psychological skills we've learned from our experts is something called a recap. And what a recap is during a difficult or stressful resuscitation case, the leader may momentarily pause, review what's been done for the patient, look ahead to next priorities, and ask team members for input. This does a few things. It can offload cognitive overload in the leader. It can also build trust in the relationship of the team and allow the whole team to perform at a higher level. These three key things that have come out of our work and the work of some of our colleagues, mental simulation, selective attendance to information, and psychological skills, seem to be those three things that can best differentiate experts from novice performers in managing cognitive overload. But doctors need to practice this because medicine in the emergency department, with all its distractions, is about more than just the science. If you want good patient outcomes, you have to be able to choreograph and to actually make things happen in real and practical ways. What we've been doing with this research is we've been trying to instill these ideas into the education of our junior doctors. We put them in the simulation lab, and they have the opportunity to practice these skills on plastic mannequins. So by the time it's their turn to look after you or your loved ones, they will already have developed some of these expert-level skills that we've learned about from our experts that we've been studying. So, have you ever felt so cognitively overloaded that you felt paralyzed? I'm here to tell you today that that's okay. And there are ways to combat this in medicine. But more importantly, those same lessons can help you beyond medicine. I want you to picture your favorite elite basketball player. It's the end of a tie game. He's fouled hard. There's a lot riding on the foul shot that's just coming up. He's nervous, he's anxious, he's hurt. What does he do every single time before he takes that shot? He mentally simulates the ball going through the net. Then he tries to drown out the distractions, the waving arms of the opposing team's fans by focusing on the front of the rim. And then he breathes in some sort of rhythmic fashion, and then he goes for the shot. Let's go back to the case from the beginning of the boy in the snowmobile crash. There's a lot of stress and anxiety in that room. If we don't act, that child is going to die. It's never going to be an easy case to manage. But what if our trauma team leader did the three things that we've discussed today? If just before the patient arrived, she held a pre-brief with her team and asked each individual to mentally simulate what they were going to do in the first minute after the patient arrived. Then she might look outside in the emergency department, recognize the chaos with all the other patients waiting to be seen. She might try to put out some fires quickly by ordering some general tests on those people. Or she might ask a colleague to cover for her while she's busy. And then just as the patient gets wheeled into the resuscitation bay, she might take 10 seconds for herself. Breathe in, hold her breath, and then breathe out slowly. And say to herself, "I've got this," and start performing like the expert she's trained to be. Thanks.